Hello.
How are you?
Hi.
Hi, guys. How are you?
Good.
Doing
How are
well.
you?
Good. I'm so sorry about last week.
That's
That's
okay.
all good.
We're all here now.
Nobody even.
No one even knows. How's the
um,
week?
the week is going. It's off to a busy start already, I think. Yeah, right?
Yes. Yes.
Yeah.
Yeah,
Doesn't matter that it's a holiday week. It's still a Monday.
Yeah.
exactly.
Listen, I know we have limited time, so I guess we'll just go. Everybody, what's up? Welcome. My wife and I, Tahani, here are doing an IG Live with Spring Fertility and Dr. Zore.
Is that how you pronounce your name, Dr. Story?
Yes.
Okay.
Story rhymes with story.
I love
Fair.
that. I love that. So most of you all know me. I'm a blogger. I'm an actor. My wife is an attorney. Go ahead. Do you want
Public defender.
a public defender? All the things.
Yep.
And I don't know. Do you want to share more about yourself before?
Sure. Yes. I'm at Spring Fertility. I'm in San Francisco location in our Soma location. I originally am from Indiana, did my med school and residency out there, and then came out to LA for my fellowship, and then Spring Fertility in 2020 in the middle of like the pandemic and all the craziness of the world. And it's been great. I love being here. And I love that we're having this conversation today.
Same.
Awesome.
Congratulations on the journey, by the way.
Thank you. Long, but you guys know that too.
Yeah.
Okay. Well, I will kick us off. So, the obvious thing, right, is that in order to become pregnant, we need sperm. That is like the one thing that we know for sure, that we cannot be pregnant without sperm. So I wanted to talk to you a little bit about the difference between anonymous donors and what the requirements are, whether it's like generally within the fertility process or also just within Spring Fertility, what their requirements are for known versus anonymous.
Yeah. So definitely kind of that's always the start of the conversation is like, does the couple know if they want known or anonymous sperm donor? For anonymous donor, we would send you a list of banks that we've worked with. Certainly there are other banks that you can get sperm from as well. Usually those donors have been screened already for genetic carrier screening, infectious disease labs, and they have been like deemed eligible to be an anonymous sperm donor. And we work with you to get that sperm sent over to us and coordinate everything for like if we're doing IUI cycles in like either a natural IUI cycle with your own period or medicated, or if someone is doing IVF. Known sperm donors are also a great option as well. They require just a little bit more work and just coordination, but both are great options. And for known donors, the main difference is that we're going to have you guys draw up a legal contract just so everyone is aware of like their roles in the process, that this is a known donor and not necessarily going to be like the parent that is going to be either financially or like in the life of the child, but that's going to be something that you guys would all work out. Everyone kind of has that discussion. That person will then come in for a semen analysis in infectious disease labs to make sure that there are, again, no surprises on that sperm count. And then we do some testing on him for FDAs and we freeze sperm. And then now we have that for availability for different treatment cycles.
Cool. And so I know that you about testing and the process. It's getting hot in here. We had the heat on because it's I don't know if it's freezing here.
Yes.
Testing for both known and anonymous.
Mm-hmm.
I have some friends who have engaged in the process, and they've talked about quarantine period. Can you like explain a little bit on that? When Spring Fertility does that, if that's like a universal requirement, and what that actually it is?
It's not, and I guess certain clinics do things differently. So with our known sperm donors, we typically would have them come in for like FDA testing. So we do like a separate infectious disease, making sure that they don't have any, knowing if they have any infectious diseases. So we know how to quarantine the sperm. But then we do specific FDA testing on the sperm, where we do like a whole history and physical exam on them. We draw like FDA guided infectious disease labs. And then usually about a week later, we have them come back in and actually freeze sperm in our clinic. So it's now FDA eligible to be used as a donor. For some people who don't do that specific FDA screening and sperm freezing, there is a quarantine period of up to like 6 months that you may have to undergo. Anonymous banks typically have a very long screening process for their donors, where if a man is donating, if a person is donating that day, their sperm won't be eligible like the next day. There's gonna be a quarantine period for the infectious diseases and repeat labs. And so it's not like a 6-month period, but every clinic is different. And so you definitely want to chat with the clinic you're talking to and see like what that looks like for them. And also important to know, like, even if you're choosing a known donor and you're gonna do this on your own at home with like home kits, I would definitely still recommend infectious disease testing, just again to keep you safe, and genetic carrier screening to make sure that you and the donor don't have anything in common that could be passed on to future offspring, or at least that you're aware of it before proceeding. And those are the 2 things I would recommend for anyone, even if you're not going to do it with a clinic and you're going to choose to do like through the home route and home insemination.
Cool. And how many diseases does the genetic testing test for?
So that depends. It can be as limited as like 3 or 4 of the most common serious mutations, or our panel that we're doing right now has over 400. So you can screen for over 400 genetic mutations to make sure that you and the donor don't carry anything in common.
Super informative and probably really important.
Yeah. And for anybody who's joining, and I don't really think I said this at the jump, but we are having a conversation about the fertility process, the fertility journey. And so to expand on what you just said, can you touch on reciprocal IVF versus IUI and IVF versus RIVF?
So many
acronyms. There's so many acronyms in this field. And yes, I think it's important just to know, like, when we are thinking about someone getting pregnant, what do we need? And we need eggs, we need sperm, we need a uterus. And so typically if it's 2 people that have ovaries and a uterus, we have a lot of options for how we're going to get eggs in a uterus, and we need sperm. And we kind of talked about the sperm route. For all the other options you mentioned, there are different starting points. And I would always say, like, what is going to be best for you is 1, based on your goals, and 2, based on maybe numbers of kids that you want and the age at which you are going to be getting pregnant. If I have 2 40-year-olds who are coming in and they are like, we really want 2 or 3 kids and that's like our dream family, that's fantastic. But maybe IVF or reciprocal IVF is going to be your best option instead of doing like IUIs. IUI, just to kind of like take out the abbreviations, IUI is intrauterine insemination, where we are taking sperm, we wash it down into a very small amount, and we put it directly back into the uterus to help, facilitate pregnancy rates. IVF, or in vitro fertilization, is where one person with ovaries is going to go through the IVF process of stimulating their follicles, their ovaries, to make a lot of eggs. We have an egg retrieval to get out those eggs, and then we do IVF by combining the sperm and egg outside of the body in the lab to make embryos. In a traditional, or I guess conventional IVF, the person whose eggs we use, we put the embryo back into that person. We have another option of reciprocal IVF, where we can take that embryo and put it into the other partner with a uterus. And that allows for both people to be part of that journey of, having a child. One person is donating their eggs, the other one is carrying that pregnancy, which has also a very profound impact on that future child as well.
And you mentioned earlier about home kits. Another acronym that I just learned, is it ICI?
ICI, yes. That is where sperm just goes into the cervix, or you can even put it in the vagina, and hopefully that sperm makes its way into the cervix, up the uterus, and down the fallopian tubes. Through studies, usually IUI, putting the sperm into the uterus, is going to be more effective than cervical, but certainly less expensive if we're doing the home route over like going into a clinic and paying that cost for the IUI.
And that's what I was going to say, that the IUI on clinic by you or one of the doctors at the New York office.
Correct.
Fertility clinic. And then IVF would be done like by his partner, or could it be done by like somebody else or a nurse? Like who would be the person, or could be the person to be doing ICI?
Yeah, usually if you're in any fertility clinic, whether it's like you're seeing a physician's assistant, or nurses, usually they can do IUIs, because we will, place a speculum and we'll put that catheter directly into the uterus to do an IUI. ICIs might be a good option if maybe it could be a doula or anyone else in the medical field who potentially you get a home kit and they can do ICIs, or even like vaginal inseminations. And so usually in a clinic, it's going to be an IUI. If you're at home or trying to just kind of take that as most of the natural approaches you can, it might be more of an ICI or a vaginal insemination.
Is there a, a number of times that you would recommend somebody do an ICI or IUI or IVF?
I would say also depend on age and what other factors may be at play. But usually after about 6, maybe 9 cycles, certainly up to 12, if you're kind of 12 cycles of doing IUIs or ICIs, it's probably time to think about next treatment, which at that point may be IVF. There may be something else going on besides just not having sperm as to why you're not getting pregnant. And we need to kind of do that further evaluation. And maybe at that point, it's a case of IVF may be the better route to conceive, because there just could be other things at play that we just don't know about, like egg quality or sperm quality. There might be a tubal factor that we weren't aware of, and so just other issues that could be at play.
Okay.
And these would be things to potentially look into before you decide what process.
Exactly. Yep. And even if you're thinking like, I want to do this at home myself, like it's very like out of the clinic as possible, I think it's always good to have an evaluation for anyone trying to get pregnant, just to make sure like you're healthy, your thyroid's normal, like you're immune to everything you should be immune to. We've done your infectious disease testing, and then we get a plan and make sure you have regular periods, that you ovulate, and then we have like a plan moving forward for like the best treatment path for you.
You mentioned ovulation. That's something that like seems like it's really easy to track because there's all these apps and stuff. But I mean, I've just like sort of looked into the apps on the Apple App Store, and there's so many different apps, and I don't really understand what it is that we're supposed to be tracking. Like when we're fertile, when we're not, when's not a good time, when is a good time. So can you talk a little bit about?
Definitely. Ovulation, definitely one of the keys. And that's for anyone that's trying to get pregnant, is that we need to make sure you're actually ovulating. Usually if you have a regular period, so between like 21 to 35 days, 99% of women on average, 99% of people are probably ovulating in that cycle. If you're having consistently like pretty regular-ish periods. To make sure you're actually ovulating, it's go to track it and just see like how long are your cycles. When do you notice maybe cervical mucus change, or when do you notice like breast tenderness, to get an idea of like what your body is doing throughout the month. Usually the apps that you use like on your phone are only as good as the information that you're putting into it. So the app usually assumes that you're going to have a 28 to 30 day period, because that's like regular, and that you're going to ovulate exactly mid-cycle. But that is not the case for the majority of people who are actually checking ovulation. And so I also like to encourage people to use ovulation predictor kits, those are the ones you buy at like CVS or Walgreens.
It's like the
little stick. Yeah, little sticks you pee on. You do that usually starting with cycle day 8 or 9. Do it for like 2 weeks or so until you get a positive, and then you stop. But that positive really gives you an indication of you're about to ovulate. That surge in your brain is happening. You're going to ovulate in the next 24 hours or so. And then that just gives you an idea of like when you're tracking on your phone, you'll now have just more information to put into your phone, then it can kick you out better information. And so the phone is really only as good as like the information you're inputting. And so if you never check your ovulation kits and you have no idea when you ovulate, you could be having like intercourse or doing IUIs or ICs at the completely wrong time to even get pregnant in the first place.
What if you have an irregular period?
That's a good question. So if you have an irregular period and you're outside those windows, we should have that evaluated. Because at that point, you conceiving like on your own or with the help of inseminations is probably not going to be working, or it's going to be a very low chance of working. Usually with irregular periods, like PCOS, for example, where people might have like very irregular cycles, it's not that you can't get pregnant if you have PCOS. It just makes it a little bit harder because you don't know exactly when you need to be having sperm like introduced into the uterus to be able to get pregnant. And so there are meds that we can put you on, like oral medications to help with ovulation, or ruling out other reasons as to why your periods might be irregular. So that's certainly a sign to be evaluated for.
Last question on this topic, and then we'll talk about egg freezing. But a lot of people, I think, shy away from IVF and IUI. All the stories about the injections you have to take and all this kind of stuff. I know it's something that felt a little daunting to me, especially somebody who doesn't like turn to medication, you know, unless I have to. So can you talk a little bit about like what that looks like and maybe what some of the side effects could be, what the side effects are? Yeah, because it feels a little scary having to like inject yourself once a day, all these for
It
however long.
does, with like 3 different shots. And certainly
Yeah.
if you Google anything, you're going to see like horror stories. You're not going to see all the other cases, the horror stories you see. So speaking also from experience, because me and my husband at the time, my husband now, we did embryo freezing several years ago as a just in case. That was kind of my like egg freezing, my embryo freezing as a backup plan. And I will say, like, as a fertility fellow, when I got this box of medications, it was so overwhelming. And I like counsel people on how to use these meds all the time. But that box you get as like a new patient is insane. It's like huge. There's so many meds. I will say, I think so big, right? It's huge. I was just like, how is someone supposed to use these medications? But I think one tip is I always recommend just whatever you need that night or that moment, take it out the box, put it in front of you, and leave everything else alone. It's not as overwhelming when you have like 2 shots in front of you or 2 vials of medications instead of like 30. The shots themselves, I think for most people, it's more of a mental game of like, I need to get over giving myself an injection, like sticking myself with a needle. If you're not used to that, it's just a kind of a weird thought to get around. I think it takes a couple days to get used to, and by that time, I think after 3 to 4 days, you kind of get the hang of it. I think my little tips and tricks for like pinching the skin, icing also helps just to numb that area, like pinching really hard though, so you're like numbing all the nerves and everything, and injecting. And then your common side effects or symptoms you're going to feel are just really that bloating, fullness, kind of like, you know, jeans will not be your favorite outfit choice in this process. I always tell patients
Not our
it will
favorite.
go away
We'll just go
at
back to
all. COVID, exactly. Since COVID, leggings are everyone's favorite. That's what we wear. So that's what you're going to wear during stimulation. It will get better, but it's going to be that bloating, the fullness, some constipation, or your common symptoms during IVF. About 5-ish days after the retrieval, all those hormone levels are falling. You will get back to your normal self. Any kind of water weight quote gain that you may have had, that will go away. It's just your ovaries retaining fluid, retaining water, your body retaining water. So that's kind of like the nitty gritty of IVF. And I always say, like, I think it's great to have like looking online, having that community of people like going through this process. But I would always, don't dig that deep. Don't hear every horror story and take that's going to happen to you. I'd say, most people do very, very well, but certainly it's not going to be the most fun thing that you ever do in your life. I'm sure you would have been rather doing anything else besides giving yourself a shot, like for those 2 weeks, but you will get through it. You can get through it. But
yeah.
you need a
Can
baby.
have a baby.
Yes, exactly. It's for a good cause. So yes, that's kind of like the IVF, what to expect.
Okay. Well, that brings us to egg freezing. That process. What does that journey look like?
Yeah. Egg freezing, great option for people who maybe know they want kids, but not right now. They're doing, you're doing other things in life and you want to keep the options open. Maybe you don't know if you want kids, and it's just, again, it's an option to keep open for the future. I think it's always important to know that egg quality declines over time. People with sperm, they make sperm every day, all the time for their entire lives, whereas we have a limited number of eggs. Over time, our numbers will go down, the quality will start to change, and so we see that ability to get pregnant or that increase in miscarriage rate happening as we're getting older. And so egg freezing is just a way to, you're going to go through the stimulation of IVF in terms of stimulating your ovaries to get as many eggs out as we can based on your follicle count to freeze eggs for the future. I think it's always important to note that no one can ever guarantee you that egg freezing will work. Even if I have 100 eggs from a 30-year-old, I can't promise you it'll work, but it certainly gives you more options than if you had none, if you're now choosing to get pregnant later in life, potentially. So I think it's just always a good way to keep options open, understanding like, is it right for you or not? And I think it's just great to have that consult, look into it. You may choose, like I learned, and I'm okay not doing it. And then that's okay. You're making a great informed decision for your health and your body. I think it's all the stories you hear of people who said, I wish I would have known about this, or I wish I would have done this sooner, where yes, like I want to avoid having those conversations with people.
Yeah. And 2 questions. One, about when should is the cutoff period for, like, freezing your eggs? Like, is there an age for women where it probably won't happen? And then two, how long
Are they
do
good
they?
for?
Yeah, are they good for?
There was
Yeah,
an article today that people had twins.
30.
30-year-old.
30-year-old embryo. Yep. So
Crazy.
theoretically, indefinitely, though theoretically, but yep, I saw that. I posted on that one today, actually. That was a cool story. But yes, so with the egg freezing process, so theoretically, the younger the better. The younger you are to do this, the more eggs we're going to get, the better their quality. That said, does a 25-year-old need to come in and freeze their eggs? Probably not. You have a very long reproductive window ahead of you. So much could change in 5 or even 7 years, and then you're still in your early 30s, you're still pretty young. When you're getting into, like, I'd say your late 20s, early to mid 30s, that's where I would start to more seriously consider egg freezing, especially if you're at a job that has a benefit that maybe you won't have in a couple years, or maybe they're talking about restructuring, utilizing your benefit to have this as a backup option. Data, we have less data over age 40. A lot of clinics will have age cutoffs for egg freezing because the success rates are so low when you're getting over 41, 42, 43 and up. And so really the best time to do this in your 30s, in your early 30s, mid 30s, you're more likely to use the eggs the older you get when you freeze them, because you'll be older as you're trying to now have kids. But for quality's sake and in terms of numbers, usually our early mid 30s.
okay.
I saw a question on that topic too before, and you actually sort of paved the way for our next topic, which is about, like, studies representation. But I had a bold moment when I realized that just because you have a number of follicles, it doesn't mean that each follicle could become an embryo.
Correct.
Or, right? Did I
Right.
say that correct?
And so, like, two ways with that. So just because, let's say I'm going to throw out a number of 20, just because I see 20 follicles in your ovaries today, if you're starting IVF like today with that 20, doesn't mean I'm going to get all 20 eggs. Each follicle has one egg inside. And so usually I give patients, like, expectations, 60 to 100% of that we should get in terms of mature eggs, ideally. So I might get 14, and that's well within expectations. We could get 20, and that's fantastic. But not every egg and not every follicle may have a mature egg that we can actually freeze. And along that path, not every egg we get will result in an embryo, result in a live birth. There's, like, a very big attrition rate in this process where not every egg will fertilize or develop into an embryo or be normal if we're doing testing on it. And so that's why age comes into play. Is the younger you are, the more eggs we get, the better their quality, the more normal embryos we may have, or the more usable embryos we have.
Cool.
Oh,
I thought you had a follow-up question.
No, I mean, I have so many questions. We have 20 minutes left. Okay, so I kind of wanted to talk about the statistics as it pertains to age first. Can you talk a little bit about, like, when it makes sense to, so, okay, let me do a hypo, put it this way. Lots of women now are prioritizing career over, family planning or having children, and have changed the economy for, like,
Yeah.
So, women, a lot of women of different backgrounds all across the world really are deciding to start the family planning process much later.
Yeah.
Can you talk a little bit about, like, the age at which it's best to engage in IUI, IVF, ICI, and when things start to decline a bit, and what are those factors? You touched a little bit on it already. What are those factors that play into that sort of downward decline that was redundant, but that decline?
Yeah.
In IUI and IVF, and whether one should come before the other, and so and so.
Yeah. And so I would say usually, like, especially, like, kind of nowadays, I feel like a lot of women are choosing to delay getting pregnant because they want to advance their careers. They want to travel. They want to live their lives. They want to get education. Whatever that reason is, they're all amazing reasons. So I feel like saying, like, when you should start trying is completely individual. For some people, that's going to be maybe at age 30, and for others, they could be 42. And that's fine. I think it's just a matter of, like, if you know that about yourself, that's why you come in and have that conversation about egg or embryo freezing earlier. If you know, like, I am like grinding at work and I don't want kids for 7 more years, so I'm on a partner track at my law firm, great, let's freeze eggs or embryos and like take that out the way. Again, never a guarantee, but at least we have a backup option for when you are ready. In terms of like when a couple's coming in for like, what treatment option should I start with, what's best? Usually, again, mostly a factor of age and goals. I think that, if it's someone who, again, is like 40 something and they want 2 kids, doing something like IVF where you can get embryos, you can test embryos to make sure they're chromosomally normal, and then potentially even bank them for like a second child, gives you so much more information and options than if I did IUI, where I'm trying to get you pregnant now. Because if I got you pregnant now at 40, that's great, but now you're going to be 42 and you're coming back for baby number 2, and it's that much harder to get pregnant. Had we just done IVF, maybe we could have gotten a few embryos, 2 embryos, 3 embryos to use for that second child instead of going back through this process again at 42. So I always say it's like a matter of like goals. Finances are going to play a big role in most people's decisions. We are very fortunate out here that a lot of people in the Bay Area have coverage for IVF, and certainly in New York, because of tech companies and finance companies. But that's certainly not everyone. And so finances play a big role in what treatment option people pick, which I wish didn't have to exist, because IVF could be better for many people, but they can't afford it because it's expensive. And so I think finances always come into play in that decision as well.
Yeah, certainly for New York State, we do have some laws that do cover fertility, the fertility process.
Mm-hmm.
But, being the lawyer that I am, when you read in language a little bit, it really, you have to have an infertility diagnosis,
right?
First, and
which a same-sex couple doesn't have,
right?
Which is, and you because you don't, like, you're not infertile, you need a sperm source. So and so those are the caveats and why traditional insurance is not the best always in this situation, because there are some people who, it's not that you're infertile, but you need some sort of treatment, but now you can't get coverage for it, and which is just unfair. And so like, it's nice when companies offer fertility benefits that allow you to use that money or those like cycles to proceed with how you want and need to proceed.
Yeah. Go ahead.
I feel like I wanted to bring it back to the representation and
yeah.
Did you have an idea?
Yeah. So I was gonna talk about representation. So there's the science behind fertility, right, has been developing for decades, I'm sure. But because of what you spoke about in terms of representation, cost, access, one of the things that we had been talking about within our sort of circle, because we have quite a few friends who are engaging in the process or looking into the process, all of between like 35 and 40. Some are queer, ready, just career women ready for a baby now. And one of the things that we were talking about was the sample populations in these studies. And a lot of the people in our circles are Black and brown women. Mm-hmm. And how reflective are these studies and these of us and our experiences or potential experiences moving forward? So can you talk a little bit about number one, the representation in these studies over the years, and maybe how these studies may not necessarily capture
or be reflective of
our experiences as women of color, whether it's from a biological perspective, environmental, which can also lead into biological too, like all the logic. Just talk a little bit about that, because that was kind of like another light bulb moment for me. It was like, aha, we're looking at all these studies about at 37 years old, this declines, but not recognizing that these studies are primarily made up of middle-aged, upper-class white women who may have had different types of access to healthcare and so on and so forth throughout their entire lives because of the world.
Yeah. Completely correct. So like, and like, how well are our historical studies on representation and having like Black and brown women in them? Poor. They're just, historically, they're not great. Usually, Black people make up about 13% of the population. We are not making up that percentage in most studies, for probably a variety of reasons. One, care is expensive. Black, brown people tend to make less. Like you can see that in like the national trends today. We make less money than our white counterparts. So cost becomes a factor. Trust is an issue. A lot of Black and brown people have their own stories of like medical mistrust and distrust based on years of issues that we've had, from like Tuskegee studies, Henrietta Lacks, all these issues that have happened in the past to where we don't trust professionals. And so then we don't want to get care. We can't get care. We feel discriminated when we do have care, so we don't want to go back. So there's like a host of social issues that are coming into play. I think religion for some people, and tends to be a lot of Black or brown people who, if you're very religious, your religion may say IVF is not allowed, or whatever that says. And I guess my argument to that is that God gave us this ability to do this treatment and provide you this care to let you have a baby. So there's a lot of different issues that we are working with. And so representation has usually been poor in studies. I think it's important to note that usually in some studies, Black women actually have twice the rate of infertility, but receive care less than half the time, for all the reasons I mentioned, from cost to access to discrimination to not being able to find a doctor who looks like them, because we as fertility doctors who are women of color represent like less than 2% of all the fertility doctors in the country.
You said that
2%. 2% of us. There are 2% of us. I can probably list the 50 of us that exist. I mean, and there's not a lot of REIs. There's not a lot of REIs to begin with, but we're 2% of that population. So
wow.
representation in medicine isn't even there. And so there have been studies done that, some patients, and not all, but some patients want to see a doctor who looks like them. Whether it provides them a sense of security of like, you know what I mean when I'm saying certain things because you will probably live through it. We should all be, as physicians, culturally competent to take care of anyone. But let's be realistic that we all know that not everyone is. That training needs to certainly be improved, and it starts in medical school. But not every physician is culturally competent to take care of all different types of people, or are willing to, and meet them where they are. And so representation in physicians matters, and that probably matters for patients and being able to even access and come to treatment. So for a host of reasons, Black women are not well represented and brown women are not well represented in studies. The studies that do exist show that there's actually lower IVF rates in people who do what I call fresh IVF transfers. So that means you go through IVF, and 3 to 5 days later, we're doing an immediate embryo transfer back into the body. Reason why those rates are typically probably lower is that Black women have higher rates of tubal factor disease, from higher rates of a history of maybe STDs, and also a higher history of fibroids, both of which can affect pregnancy and implantation rates. And so making studies that aren't necessarily geared towards Black or brown women, it can skew the numbers, or it can change like kind of, what we're thinking in terms of treatment options. So again, like you said, representation studies matter so we know how to best treat people, figure out best treatment path to get them pregnant in an expeditious and safe manner.
Do you have any efforts in the fertility world right now going on in terms of trying to recruit women of color to engage in studies? There are studies reflective of the experiences, that we would be having, and I'm sure that in women of color who actually are having children in the process.
There are definitely ongoing studies. There have been, I would say the studies have certainly increased in the past probably 5 to 10 years, where they look specifically at like comparisons between Black and white women and looking at pregnancy rates, looking at access to care. And so those are definitely ongoing. I'm not aware of any like massive studies that are happening like on a randomized prospective basis where they're actively recruiting people. That certainly could exist, but we definitely need it. And it's just the studies that certainly have been done up until now show that disparity or discrepancy in care. So it's important to have that conversation.
With that, I think it was about a week or two ago, the Washington Post posted something about like a lot of donors as well, Black and brown donors. I think this article is specific, correctly, to Black donors.
Yep.
What I don't even know what question I want to ask here.
Why is it so low?
Why is it so low? And
first of all, what is the number? What is the number Black and brown sperm available.
Right.
That's a good question. I would say like the COVID and the pandemic like worsened donors for everyone because donors couldn't actively come in to give specimens. So there was actually like not a shortage of sperm, but there was definitely like people were struggling to find
The irony.
sperm they wanted. Yeah. And in that sense, you know, it goes back down to culture. When you know when you think of like historically IVF, you think of like white heterosexual couple. And when you're like looking at old pamphlets or people who used to talk about IVF, it was kind of like white people, straight couples going through IVF. You didn't see like same-sex couples. You didn't see like Hispanic women or Black men and women. And that's probably to do with culture, in that we feel that we're not supposed to have infertility because I don't see anyone who looks like me not talking about it. So I shouldn't have this. Like, it can't be. And so one, the conversation needs to happen, which is what we're doing now. And like celebrities with platforms have had that conversation, which I think just opens the light. Like Michelle Obama talking about her miscarriages in IVF was huge, because you're seeing someone who looks like you, who went through this, and you're realizing that this can happen to anyone, not just, you know, to whatever group we want to like pin infertility on. It is a true global problem. It does not discriminate. So I think just being aware that we have to have these conversations. The donor aspect, hard to say. I think it's going to come down, I think it comes down to like cultural reasons as to why we don't have a lot of Black, Asian, Hispanic egg donors, similar to sperm donors. And whether that's a cultural thing of not understanding like what that entails or not feeling comfortable doing that, hard to say. I've certainly heard differing opinions from different people when I've discussed both of those. But I think it's something that's just not as talked about in our cultures.
Yeah. Is there now because there's you know, those sort of groups of people in terms of egg donors? I don't think I can talk about, if we have time, like, touch on that, because we have friends actually who have looked into egg donors instead of necessarily sperm donors. But oh shoot, now I lost my train of thought. Oh goodness. We were talking about representation. In terms of like cost, right? Because like when you're purchasing sperm from the sperm banks, like one vial of sperm can run you a lot of money.
$800. Yep.
Yeah. Like, you know, you may not need it, and I know the banks allow for you to like sell it back at a certain percentage and stuff, but like, because the like Black and brown and Hispanic sperm is sort of like a rarity, is there an in cost in terms of the sperm? Do you know?
I am not aware of that. I don't think so. If you're going to a standard bank, I don't think that they would discriminate on cost, but that's a good question that I don't actually know the answer to. I have not looked it up, but now I'm curious, so I'm going to tonight.
I have like 5 minutes left, so I want to talk about the egg donor process, like what that looks like, because that was also something I feel like almost embarrassed to say it. As like a 37-year-old woman, I kind of feel like I should know that like people also donate their eggs as well as sperm. It had no idea that was a thing.
Yep. Most clinics, and there are certainly like a lot of donor egg banks. Usually the donors are under 30, so we're looking for usually like younger people who are hopefully having a lot of eggs and they have good egg quality. They go through that same process that you would think about like with egg freezing, where we're going to stimulate their ovaries. We're going to get usually a decent number of eggs, and they can get frozen. And then people have the option of purchasing eggs in quantities. So a lot of times it's like 6, 8, or 12 frozen eggs. And because these are young donor, it's like literally not really cartons of eggs, but that's how we're thinking about it. So it's usually in batches of 6 to 8 or 12. And you're gonna like purchase whatever number is gonna feel comfortable for you for the family that you want. They get thawed, they are fertilized with partner sperm, donor sperm, and we grow embryos. And so that is certainly another option as well, for people who are looking to who need egg donors. These are typically going to be either women who went through menopause early, or people who maybe have poor ovarian reserve, maybe are older and they tried IVF with their own eggs and it's just not working, and so they're going the route of an egg donor now.
And so you mentioned that
we
there
have
was
4 minutes.
I know. There was an age cutoff for the egg donor. Is there also an age cutoff for sperm donors?
I'm sure there is. I don't know off the top of my head, but there probably is. Like, I do not think they're letting 65-year-olds go in and donate sperm.
I
But,
like, I mean,
you know, yeah, it's possible. And some people want to
yeah,
make money, but I'm not sure how.
Yeah.
Like, yeah.
it wouldn't be the best sperm at 65. But yes, there probably is. There's definitely an egg donor cutoff. Most clinics are going to have 30 as their cutoff. Sperm, I imagine, is probably under 40 or they're under somewhere in the 30s range. So yes, and that really is more like quality. We want to, if people are going to be purchasing eggs and sperm, we want to have ideally good quality sperm so that it is successful.
And does Spring Fertility give the option of helping like queer couples navigate like surrogacy?
Definitely. Yeah. So we partner with different agencies. So we have like lists of agencies that we work with. We provide that to the patients if they're asking for surrogates or gestational carriers. And then you would work with that agency directly. You would usually get matched with a gestational carrier. And then before we're picking anyone, like you'll send those records to your physician at Spring. They'll review it to make sure that that carrier is a suitable candidate in terms of their own health history, OB and medical history, and we screen them before we get down that path of transferring embryo back into them.
Interesting.
I mean, we can just keep going and going and going.
So much, yes.
But I know your time is limited. So I mean, there have been people in and out of this chat, so I just want to give like a minute or two for anybody there who might have a question for Dr. Zore. Feel free to just type in your question and we'll have her answer it.
Yep.
Give the caveat at the end.
I do. I'm gonna give them a second to ask because I know quite a few people were in and out.
And just people know, Spring Fertility offices in New York and in California, right?
Yep. All across the Bay Area. Yes. And then Vancouver as well.
Oh, right.
Cool.
Yeah.
I did that when we were on
I did see that on the website.
Yeah.
Yeah. Maybe you guys can head out to Europe as well.
Oh, I mean, I'm still secretly trying to get something good like down south. Where are we going next? Like, what's the new journey?
Oh, there's a question. Is it better to freeze eggs or embryos?
Good question. So I would say like twofold. Eggs, if you don't have a partner or if you're not in a committed relationship, eggs are usually your best or safest option in the sense that if you freeze embryos, those embryos are both you and your partners. If you separate, whoever that person is, has equal say in those embryos and what happens to them. Because our egg quality is going to decline more rapidly, usually eggs will be a better option if it's not like maybe a long or serious partnership where that's the person you're having kids with. Embryos give you more information though. Like if you want to know like what you have, how many are normal or how many embryos make it, that gives you more information. But they are both of your property. And so you have to be aware of that. There's a little bit of a loss rate when we freeze and thaw eggs. Usually that's about 93% of eggs should survive the egg thaw. So it's whatever's best for you. If you are a single person wanting to like freeze something, usually eggs are better. Age also comes into play though.
Okay. And we have two more questions here. The first is, didn't hear the age cutoff for women having babies. Is 40 years old too high risk?
No, technically not. So most clinics will actually allow you to have a transfer into yourself until age 54, which most of us don't want to be pregnant at 50 something. Certainly though, over age 40, there are certain pregnancy complications that may go up like high blood pressure, diabetes, etc. So we just want to make sure we're aware of that. You're talking to your provider to make sure you are also healthy to carry. If you are testing embryos, if we have a normal tested embryo, your chance of getting pregnant is going to be the same whether you're 30 or 40 or 45 because it's a tested chromosomally normal embryo.
Okay. And then this last one, because there's a few, but we can get all of them. This last one, would Spring Fertility deal with patients who have stage 4 endometriosis?
Definitely, yes. Come see us.
Good. Well, that's a great way to segue into
your
spiel.
Every question. However, you guys can reach out to Spring Fertility. They offer free info sessions each month where you can get, I have a whole spiel, guys, where you can get a lot of questions answered. You can DM them, you can DM them, email them. And also, okay, my bad. Most importantly, if you use the code Danielle, you will receive $150 off of a consultation. So take advantage of that. Every dollar helps, guys.
Yeah.
And I just want to thank you for the time to chat with us. I learned a lot.
Of course.
And so I will be reaching out to you.
Yes. And I have my Instagram as well. Again, it's Spring Fertility. And I have one, Temeka Zore MD too. Love to see people and chat with you too. So yes.
Great.
Thank you,
so
guys.
much. Happy
Thank you. You too. Have a great Thanksgiving, guys.
All right.
Bye, everybody.
Bye.